All right, let's talk about MRIs. It's a two-part lecture. We're going to talk in this first part. Oh my God, I'm going to trip and kill myself. Okay, here we go. We're going to talk in the first part about sort of MRIs and the central nervous system primarily, and then the second half is actually a little more fun. Get to talk about MRI and orthopedic injuries and sort of those sorts of things. So it's kind of a hodgepodge and a really quick hit run through MR sort of imaging and what we can do with it. How many of you have 24/7 access to MRIs? Hands high, because I'm curious about this. Ooh, there's a lot of you. You are blessed and cursed because you need to know how to use this study. It isn't the best study for everything out there, and you need to know when to use it, how to use it, and when to use contrast if you have 24/7 MR access. So let's talk a little bit about just what the imaging is itself. What MR reminds me of, what supposedly happens in there is your body gets exposed to this massively powerful magnet, and all of your protons align one direction. They all turn in the same way. And then they get unmagnetized and they relax, and they go back to where they want to be at different rates. And it reminds me of that Gary Larson cartoon where there's a guy writing on like a scientist, mad scientist, writing on a board, and he's got this big formula everywhere. Like, so there's all these integrals and things, and then he has a little parenthesis that says, and then a miracle occurs, and then something else comes out this end. That's what MR is to me. It is it's a technology that came out after I graduated from medical school. It is completely magical, and it produces amazing pictures, and I have no idea how magnets do that, but they do. Really amazing stuff. If you've ever had an MR, it's sort of like being in a construction zone in a coffin. It is loud, it is like jackhammers, it's banging, it's clunking. It is, if you've never had one, just go stand near one. It is remarkable how noisy these things are, and somehow it makes pictures. It is amazing to me how this works. And the technology has changed dramatically, and it's going faster than I can keep up with it. There's T1 and T2 imaging, there's FLAIR, there's spin echo, fast spin echo, slow spin echo, diffusion weighted, and there's also the gadolinium, which is the contrast that you throw in there. The key for those of you who have 24/7 access, unless you want to go relearn physics, which was torture the first time around, so I'm not going back and doing that, use your radiologist to know which kinds of studies are the best for which kinds of things you want. And I will talk a little bit about gadolinium as well, which is the contrast medium that goes with MR. Ask your radiologists if you need it at all for the studies that you're ordering. It might be useful, but it might not be necessary. Gadolinium is meant for vascular issues, so it's used when you're looking for vascular tumors or you're looking for vascular structures. It's used for, gadolinium's used for inflammation. So if you have an inflammatory process, gadolinium can improve the sensitivity of the study itself. First-time seizures it's used for. It's not necessary in all cases, though. So honestly, rather than kill yourself trying to learn about MR technology, just use your radiologist and ask them what you need to order, what kind of study. You may not have access to all these T1-weighted, diffusion-weighted, FLAIR technology with your scanner. So find out what you have and use your radiologist for this stuff. Gadolinium we're going to talk a little bit about in the second part of this talk. It's important to understand what it is and what it may do bad. So we'll talk about that in the second part of the talk. One of the advantages, a huge advantage to MR over conventional CT imaging, is that MR has no ionizing radiation. We talked yesterday about the downsides of ionizing radiation. And when we get into certain areas, it's going to be important that ionizing radiation is a factor, particularly in children. And it may be that MR is a better study in certain things, particularly in kids. So what you need to know when you go back to your joint is what kind of scanner you have, what its capacity is, and then ask your radiologist sort of when you're thinking about getting an MR, what kind of study is the best. So that's the general gist of MR. Let's get down and talk about CNS pathology and MR imaging. There's a really nice review article on abstract number 1. It's a 2000 paper. This is actually, all things considered, 8 years later. It's almost an antique paper, but it talks about the CNS pathology where MR imaging is particularly useful. We'll talk about these in detail, but it's spinal cord pathology or compression, acute cerebral ischemia, and we'll talk about whether that's crucial to diagnose or not. We'll get there in a sec. Central sinus thrombosis, and this is very helpful. It's way better than CT scanning for central sinus thrombosis. Carotid artery dissection, it's pretty good, although CT angio is also pretty decent in that. Vasculitis and encephalitis of the brain, subtle CNS hemorrhage, and then it's not good for bony stuff. And we'll come back to that as well. It's a nice summary paper for you there if you want one that says, here's where it's great and here's where it's not. Let's get into some specific CNS stuff. Let me give you a clinical scenario. 28-year-old female comes in complaining of hemi-body numbness. The left side of my body is numb. We've all seen this. It's like, okay, fine. No hard neurologic findings at all when you go examine her. But she also mentions that she had an episode of double vision a couple months ago, and that about a year ago, she'd had problems with her right hand being clumsy. Those are lesions separated in space and time. Okay, they're neurologic lesions separated in space and time. That's somebody in whom you worry about MS. Right? They have multiple parts of their CNS involved and different time frame in which they occur, lesions separated in space and time. MR has become the diagnostic modality of choice for this, for the most part. But I have to tell you, and the paper here is actually a quite good one, that looks at a bunch of papers on how good is MR in a single neurologic instance in picking up multiple sclerosis. The way it's diagnostic, we did oligoclonal banding when I was a resident back when. You did a CSF tap, it was sent off for oligoclonal banding. They can still do that study. MR is better, but what's interesting about MR, what they're looking for is multiple lesions that tell them that there's multiple places in the CNS that have been involved. A single MR study, particularly in a single neurologic event, the sensitivity is not that great. If there are multiple lesions, it does increase the likelihood of that patient having MS, but it doesn't lock it down. So this is something that may be helpful, but for those of us in the ER, it really isn't something, even if you think somebody might have MS, it's not necessarily a study you need to order right then. It's probably better to get the neurologist involved. It's not a study that, unless they have something major dysfunctional that needs to be admitted to the hospital, it's something that can get followed by a neurologist as an outpatient, and they can get the MR, and they often get more than one to see that the lesions change over time or increase over time. So MR for us is probably not a very important study in MS, and it isn't, if it only shows one or two lesions, it doesn't lock in or exclude the diagnosis on that single day that we're seeing them. So it's not that particularly helpful for us. So that's kind of nice to know. I'll tell you where it is useful. I have MR access Monday through Friday about 9 to 4, banker's hours. Yeah, I really wish I had MR access 24/7, but for very few things. The next thing is something I really wish I had it for. Let me give you a scenario here. 67-year-old guy with a history of a coronary bypass who is diabetic, who comes in saying, I feel really dizzy, the room is spinning, and I feel sick to my stomach, and I threw up once at home. Okay, you do your exam. There's nystagmus on exam. Doesn't extinguish. Walks okay. Finger, nose, fingers a little off, but pretty good. A lot of us would treat that person with meclizine. Might get a little better. Must be peripheral vertigo. It came on abruptly. Send him home. What MR has shown us is that in those high-risk patients, the vasculopaths, the diabetics, the elderly, in those high-risk patients, because MR is a so much better imaging technology for the posterior fossa, that about 25% of those are strokes. It is a remarkable number, and this paper shows 25% as well. This isn't as good a paper as others that are out there. We all know that CT scanning is a terrible imaging modality for the posterior fossa. There's just too much bone back there. There's lots of artifact. It just doesn't show very. In fact, if you see something on CT in the posterior fossa, it's pretty big. Okay, it's pretty gnarly. Especially if you can see something ischemic back there, they've basically infarcted half their cerebellum if you can see it on CT. MR is hands down better at looking at ischemic lesions. No question, remarkably better, flat out. We'll talk about big strokes. It's hugely better. What this imaging technology has shown us is a lot of those peripheral vertigos in people that are high risk aren't peripheral. They're actually true cerebellar strokes. This is where it is very, very helpful to have an MR. I don't have a 24/7, and what we tend to do in these patients when we're concerned at all that they've had a cerebellar stroke is we either keep them in the ER till that 9 to 4 Monday through Friday thing, or call the neurologist and get them admitted. For those of you who have MR technology, here's one of the cases where you have it flat out better than I do. This is a case where you need to go straight to the MR, where you think you have a posterior fossa, acute vertigo in the elderly or at-risk group, which is vasculopaths or diabetics. Please be concerned. And I'll tell you, the cerebellum is a very interesting part of your brain. It has a remarkable amount of redundancy. You can truly infarct half of your cerebellum and still be relatively functional. Acutely, it's a little rocky, but eventually the other half takes over, and it's pretty good. It's amazingly resilient. So you can have relatively minimal findings and have a big old stroke back there. And the risk, by the way, what we're finding with MR is there are a lot of people who have strokes that we didn't previously diagnose. And the dictum used to be, if you have a posterior infarct, if you have a cerebellar infarct, you need to admit them and watch them in the hospital for 3 days. The reason is that they swell, and there's no space in that posterior fossa. And if they swell enough, they'll herniate, and that definitely can occur. What this is doing is changing that a little bit. We're picking up a lot of smaller cerebellar infarcts They don't all necessarily need ICU admission for 3 days because they don't get as much swelling the smaller the infarct. It's changing a little bit of how we approach this. The bottom line for us is suspect cerebellar infarct and get that MR study. Then you can punt it to the neurologist and they can decide how they want to handle this. They virtually all get admitted day one. Whether they stay in the ICU for 3 days like they used to is up to the neurologist because things are changing in that regard. But the bottom line is it's a much better imaging study for the posterior fossa. So that's where I wish I had it 24/7. We don't, so we watch these people closely and keep them around until we can get them imaged. How about syncope? Oh, go ahead.
Do you know of any literature since 1995 that's looked at these numbers?
Oh yeah, actually the literature, it's actually better since 1995 as far as locking in. It's the range that I've seen published on posterior infarcts for people who come in with acute vertigo in the risk group is 10 to 25%. So 1 in 10 to 1 in 4 is going to demonstrate a posterior infarct in the risk population, vasculopaths, diabetics, elderly. So it's not that I'm dizzy doctor. Find out the I'm dizzy doctor. If they're vertiginous, be concerned.
What are the neurologists going to do with that? Not much, right?
Well, they're going to watch it. They'll give them an aspirin or not, and they'll bring them in the hospital. And again, they still have the risk of edema, and they still have the risk of herniation. So they still will bring them in.
There's a lot of people that go home with strokes and stay at home.
But not in my joint. They don't go home with an acute stroke.
No, I'm saying they don't even come to the doctor.
That could be. That could be. But if I identify it, they're not going home. You know, if they're sitting, I can't change the person who's sitting at home with their stroke, but I can certainly address the one that's in my ER. So, okay, let's talk about syncope. Should you be doing MRs with syncope? No. Nor should you be doing CT routinely with syncope. That's abstract number 4. The bottom line is, for syncopal episodes, unless you have a hard reason to go for the CNS, it is pretty rare for a CNS lesion to cause syncope. The things that can do it are subarachnoid hemorrhage. So somebody who goes down and wakes up going, whoa, man, I've got a headache. That person gets imaged. Okay, and we'll talk about how good it is for subarachnoid in a second. But overall, most syncope is either unidentified source, half of it, or it's cardiac are the biggest risk. Can it be neurologic? Sure. But don't go straight to imaging the brain at all unless you have a hard neurologic reason to do so. It shouldn't be a routine part of a workup for syncope unless you have an absolute reason to do it. And MR is overkill when it comes to syncope. Now, how about TIA and stroke? The best paper in this section is abstract number 6, and it's worth asterisking because what it tells you is what you get from CT versus MR in somebody in whom you think they had a stroke. TIAs in general, we tend to image mainly just to look for the old stuff, not today's stuff. If their symptoms have resolved with a TIA, we often don't see anything, but we may see from today, but we may see something from their past event, when they threw a little clot last time or they had a little stroke last time. What we look for the stroke is we want to see ischemia, and you all know, well, we want to see two things. We want to see ischemia or whether there's a bleed. You all know flat out that CT scan stinks in acute ischemic stroke. It's terrible. It's absolutely terrible. It's ghastly. MR is way better than that, and the numbers are here. For an acute ischemic event, acute ischemic stroke, the sensitivity of CT scanning is 16%. Okay, it doesn't. We know that. It doesn't see it acutely. The sensitivity for MR is anywhere between 83 and 87%. In this study, it's 83%. Way better for acute ischemic stroke. And I'll come back to TIA in a second. The problem is, that's fine. If somebody's hemiplegic and they have a negative CT scan, I'm still going to keep them in the hospital. I'm still worried about the stroke. I know the CT is negative. What I want to know in that CT scan, if you're especially in a stroke center where they're thinking about thrombolytics, is I want to know bleed. Okay, is there a bleed there? CT scan turns out to be better than MR for acute bleed by about 5% in sensitivity, enough that it makes a difference. So if you're getting an imaging study to look for whether or not I can thrombolyse this person, is there a bleed? That's my question here. CT is the better study. If you're getting the scan to say, I need to know if they've had an ischemic stroke, MR is the better study. So know what you get from the study you order. The other thing that's been really interesting about MR technology with TIAs, you all know that the definition of TIAs has been completely redefined. I was taught that a TIA is a transient neurologic event where the neurologic findings lasted 24 hours or less. That's what I was taught. That was back when. That was the definition. That has changed. It is now 1 hour or less. And the reason it's changed is because MR technology is so much better at seeing ischemia than is CT technology. As we started MRing more of these patients, we found true strokes in the TIA patient whose symptoms lasted 8 hours or 10 hours or 12 hours. They had a true ischemic event. So TIAs now are different than they used to be. They're defined differently than they used to be because, and by the way, most TIAs, when you really look at the literature, are 10 minutes or less, which means for us, by the time they come to us, the symptoms are gone. That slurred speech and my hand was clumsy is gone. You have to trust the history or the collaborative history from people who were at the scene. So that it's made our job more difficult. But TIA has been redefined. The approach is much more aggressive because in 48 hours, about 1 in 20 will go on to the full-blown stroke. So we know that there's a high-risk group. TIAs have become a whole different ballgame. Imaging-wise, though, if you're worried about a true stroke, the MRI is better at ischemia, but the CT is better at the bleed. And if you're thinking about thrombolytics, go to your CT scan. It's the better study to do. So that's the approach on that. I mentioned the subarachnoid hemorrhage thing. So you have that person who has the syncopal episode, comes up clutching their head when they finally come to, saying they have a terrible, terrible headache. Can you use MR to rule in or rule out subarachnoid hemorrhage? Abstract number 9 looks at this. When you go back to your joint, it needs to be a specific type of MR technology that will pick up a subarachnoid bleed. It's FLAIR technology is the best of them. So go back and just ask your radiologist if it's. And I tell you what it doesn't get you. It does not get you off the hook having to go to LP if it's negative. So far, there are now 2 more papers this month looking at CT scanning. Are these new fancy schmancy scanners like we have now at Harbor good enough to obviate the need for an LP? The answer is no. MR isn't good enough. There is no CT scan that's good enough yet to get you out of having to LP somebody in whom you're concerned about a subarachnoid hemorrhage. This one misses 7%. The new CT data that came out this month missed 3 to 7%. So and you can't miss that diagnosis. It's a no-miss diagnosis. You cannot miss it. The morbidity is way too high. You can't miss it. So that's the deal with that. How about, let me see, evaluating kids with headache. Let's abstracts 11 and 13 look at kids with headaches and whether MR is a good idea. The best of this is actually 13, but both of these papers are a little skewed. One is from a pediatric neurology practice. One is from a tertiary care center. These are not your run-of-the-mill kids with headaches. This isn't the kid who's the tummy ache kid sometimes because they don't want to school, and today is the headache because they don't want to go to school. These are kids that were referred for specialty care. These kids, in abstract number 13, 9% ended up having brain tumors, and kids are more likely to have posterior fossa tumors than they are sort of cerebrum tumors. They're more likely to have posterior fossa tumors. The bottom line, if you're worried about a brain tumor in a kid, and the things that make you worry are headache upon awakening, vomiting, neurologic findings, no history of migraines in the family. Okay, those are the things that should make you worry. Kids don't complain of headaches much. They complain of lots of tummy aches, but they don't really complain of headaches a lot. And if a kid really has headaches, especially if it's persistent, progressive, wakes them up from sleep, it's there when they wake up, they have vomiting, neurologic findings, or no history of migraine in the family, that's a kid you need to worry. And this is where MR is great. I don't want to radiate a kid's brain if I'm trying to work them up for a brain tumor. MR is great. It's non-ionizing radiation. It is great at viewing tumors. It's wonderful. The downside is it's scary. It is a coffin in a construction zone. It is scary. So you often have to sedate kids. And they're sedated in a tube that you can't get to very quickly. If they flip out in there or if they have an episode of apnea or vomiting or whatever, it's a problem. If you have an open scanner, it's better. But if you don't, you still may need to MR these kids and you may need to sedate them. But it is a good imaging study for kids. How about in head trauma? I'm going to skip all these next to these papers and cut to the chase on acute, sort of mild to moderate head injury. There's a whole bunch of papers in here that look at this. The bottom line, we're going to go through all of them because there's a bunch. The bottom line on acute head injury. For us in the emergency department, CT scanning is completely adequate for what we want to know with acute head injury, which is things that need to be acutely intervened on. So the subdural hemorrhage, the epidural hemorrhage, the things that in an acute injury, somebody's going to want to go in there and do something. MR is more sensitive in picking up non-surgical lesions. Brain contusions, it's better. Okay, the little bit of blood in there that's kind of diffusely through the brain, it's better. But that's not something anybody's going to operate on. So for those of you that have the access to both, and you have a mild to moderate head injured patient, go for your CT scan. It gives you plenty of information on what needs to be intervened on. And your MR will pick up more injuries, but they tend to be injuries that aren't necessarily important to acute intervention for at least our purposes. So overall, it's better in a mild to moderate head injury to go right for your CT scan. The only instance where that is not the case is the child who may have been abused. We are a child abuse referral center at Harbor. It's an incredibly depressing thing. We see an unbelievable number of cases of this. In kids in whom you suspect child abuse, there are 2 papers in this stack that look at it. It turns out that anywhere between 10 and 25% of kids who are abused, who get an MR of the brain, show some sort of brain injury. It's more sensitive at picking up shaken baby syndrome than is CT scanning. MR is better. So it's one of those things, if child abuse is in your list of things you're concerned about when you're imaging the brain of a kid, go to MR. And those of you who have access to MR, you may want to use MR as your imaging study for abuse or for traumatized kids anyway. It's non-ionizing radiation. It'll pick up more injuries that are non-surgical, but it'll also pick up all the surgical injuries. So it's something in kids to consider doing if you have access to it. C-spine trauma. I will cut to the chase on C-spine trauma. What we care about acutely in C-spine trauma is acute bony injury that needs to go to the operating room. Okay, that's what we care about in acute C-spine trauma. So CT scanning is the better test. If, however, you get that CT scan and it's negative and there are hard neurologic findings in your patient, a bilateral upper extremity weakness, you're worried about central cord syndrome, Brown-Séquard kind of symptoms where they have pain and temperature on one side and sensation and weakness on the other, that is worth then going to MR. But acutely, CT scanning is just fine for what we need to know on acute cervical spine injuries in the emergency setting. So CT is fine. MR is better for the cord and the ligaments, but we aren't worried about that on the first set of imaging. It's that next round where you may want to consider it. And actually, there's a couple papers that look at sort of upstairs in the patient that doesn't wake up. Do they need to go on? If they can't assess their neurologic function, do they need to go on to this? They do sometimes, but for us in the ER, it's not the first test. The first test is CT. Only go on to that if you have hard neurologic findings and there's nothing that shows up on CT scan. Now, the posterior fossa is where I wish I had 24/7 MR, and this next 2 items are the other area where I really wish I had 24/7 MR. A child comes in, let's make this an adult. A diabetic who just went to the dentist a week ago and had a root canal comes in to see you complaining of thoracic back pain. They may have had some sweats at home, a little bit of numbness and tingling in their feet, but you can't find anything on exam. And they have pain right here. It's really uncomfortable. What are you worried about? Epidural abscess. How good's your white blood cell count?
Could be normal.
Terrible. 75% or less than 10. Have a white count of less than 10. How good's your SED rate? Depends what your cutoff is. If you drop your SED rate cutoff to 20, I'm going to say use 20 as my cutoff for a positive SED rate. It's great. But in a 67-year-old, a lot of people have SED rates over 20 as just the nature of the beast. It's terrible. How good are plain films? Ghastly. Ghastly. Terrible. Spinal epidural abscess is a very scary thing. And abstract number 28 looks at a bunch of them, actually. This is some cases they reviewed. It's 63 patients over 10 years they reviewed in a single institution. Half of the patients in this, of these 60-some, had been seen in the emergency department at least twice prior to diagnosis. When they had hard neurologic findings, half of them maintained them after decompressive surgery. What you lose most of the time. They don't get it back. So when the neurologic stuff is there, they don't get it back. And the classic triad we were taught of fever, spine pain, and a neurodeficit, well, its specificity is great. 99%. If they have fever, back pain, and they have weakness and numbness in their legs, great. But my goodness, I mean, a first-year medical student could figure that out. How sensitive is that? 8%. You don't get those 3 things when they present to the emergency department. You get back pain most of the time. The first complaint is almost always just back pain. It can be anywhere in the spinal column. It tends to be low T-spine, just so that you know, because that's where the artery of Adamkowitz comes in. It tends to be low T-spine is where most of them occur, but they can be anywhere. Low T-spine is the place they tend to be. The group you're going to worry about it is people who are diabetics, IV drug users, those with significant liver dysfunction, disease or failure, anybody with indwelling catheters, and people are going home with PICC lines these days a lot. So anybody with indwelling catheters, HIV-positive patients, people who have had spinal procedures or recent dental work. Those are the groups in whom you have to consider it. The best imaging study out there is MR. You can do a CT myelogram that has a significant morbidity to it, tough to do. Okay, it's not a great study overall. MR is way better. The other time somebody's complaining of the other scenario to worry about is, I was working in the backyard, I was lifting something heavy, and God, my back hurts right here. And it's weird. It's like my side is bugging me, and this side's bugging me. That can very well be a thoracic disc. Most disc ruptures are low. The thoracic spine has the smallest area where your cord lives as far as in your whole spinal column. It's the narrowest point. It's your thoracic spine. If you rupture a thoracic disc, what you'll do is if you first hit the foramina, you're going to get basically a radiculopathy. All that comes out of that foramen is the nerve to the thorax at that level. And actually, it's more like here. If it's T12, it's down just below the belly button. They'll say, I have pain here. It's radiating pain. You're going to think it's a kidney stone. It's not. They ruptured a disc. The pain comes around like this. It's pushing on the foramen. And if it goes midline and it pushes on the cord, they'll get a cauda equina. They'll actually get a cord level, not a cauda equina. They'll get a cord level here. You don't have the same kind of findings from discs down lower where it radiates to the foot and they may have a foot drop or sensation changes low. All you get is here at first because that's the only nerves that come out of the foramina at that level. I tell you, anybody who complains of thoracic back pain, you've got to worry. It could be a disc, it could be a spinal epidural abscess, it could be a dissection. It's not a place where you usually get back pain. Your back pain's usually here. If it's here, worry. Something's funny, worry. And you're going to lower your threshold to consider things like imaging. So for discs and for spinal epidural abscess, MR is a much better study than anything else we have out there, flat out. So to kind of wrap this first section of MR, it's great because there's no ionizing radiation. Just know that there are times it's better than CT and sometimes it's not. In MS, as a one-time study, it's not very good. In acute vertigo in the elderly, please have a low threshold to order it, or if somebody's diabetic, or if somebody's a vasculopath. Forget it in syncope. In TIA and stroke, know that you get better imaging for ischemia, but it's not as good as CT for acute bleed, especially if you're worried about thrombolytics, so you may want to just stick with your CT. Headache with kids, it's a good choice study. No ionizing radiation, it's a good choice. Child abuse, it's a good choice. It is overkill in mild to moderate trauma. Okay, you don't need it, it's overkill. C-spine trauma, it's only if you're worried about ligamentous or cord injury, and watch anybody with thoracic back pain. Bad things happen when people have thoracic back pain, so consider this as an imaging study. All right, any questions on the first part of MR? We get to do the ortho stuff in the second half. It's funner. All right.